All right, testing 1 4, testing stream for YouTube, testing. Testing 1 4, testing stream for YouTube, testing.
Well, welcome back. Right, first time all of us have been in the room together. It's nice to see you all. And I can see that everybody was so happy to be back that they were all visiting and nobody was showed up at 1 o'clock. Zim and I thought we were in the wrong meeting. Thank you all. It's great to see you. Today we're going to have our planning committee meeting. I think almost every member of the board is here, so we certainly do appreciate that. I'm informed of no citizens wishing to address the committee today, so we will move straight into our agenda with our item 3, which is approval of minutes from the March 4th, 2021 meeting.
Move.
Have a motion from Mr. Montgomery. Yes, ma'am.
Just add my name, I was here.
Dorothy was left off of the present.
Left off, I
Okay.
was here.
I don't know how that
So
happened.
we'll get that fixed.
Well, wait a
But
minute.
that was okay, they had me all through the minutes, Dorothy, they did.
You just weren't.
Yeah, you made the motions, but you weren't present.
Mr. Chairman, we may need to consider the motion a second. No.
All right, so I had a second from Charlie and one amendment from Dorothy. Any other amendments? Everything else good? All right, I think we're fine. Anything else, then let's all in favor say aye. All opposed, same sign. That motion carries. Thank you all very much. You'll notice the agenda today. I want to briefly address this. As we begin in earnest now, the planning committee's efforts and subsequent committee efforts that we'll talk more about today, relative to the capital program and the bond program, one thing you're going to see in terms of the agenda is we're going to try to very clearly differentiate those items that are a portion of the bond program and those items that you have all been dealing with now, in some cases for years, on the capital program. And we're going to try to keep those separated on the agenda. And we'll talk more about this later. The effort and the goal is to make sure that everything flows smoothly and that information and that process doesn't necessarily have to reflect sources and uses of funds. But we do need to make sure that we keep those funds very separate in the way that we proceed through them. So you won't see it in terms of process, but in terms of agenda, we'll try to keep those differentiated so that there's not any confusion as to what project goes with what source of funds. And Sharon will thank all of us for that before it's all said and done. So with that, on our infrastructure project update, all of you have been aware of this. It's been an ongoing project. We've appropriated, I think, $9–10 million to make this project happen. Adam, you can bring us up to speed on how we're doing on that, sir. Good afternoon.
Good afternoon. Good to see everyone in person.
Yes.
So, infrastructure project, it's going very, very well. The chiller project, if you recall, we asked for $2.5 million of the $10 million. That project actually is going a little over cost, but what's nice is the structural project, which I'll talk about as well, is coming in well under cost, so we're migrating the money to that within the $10 million. We have ordered the chiller. The chiller was shipped on May 20th. Many of you may remember in the Finance Committee, TDI was approved. It's going to the board for approval for the installation of the chiller. So once the chiller arrives, we're on. So that's a good thing so that we can get it in before peak heat season.
Where's the chiller coming from?
Train. Yes, that's the manufacturer. So I don't know the location. Probably. As far as the central plant repairs are going well. We have started demolition already. If you recall, this is the roof of the underground central plant, the structural roof. Several components of that are being removed. Several more are going to be injected with carbon fiber concrete. It's not worth cutting them out. We can reinforce them by doing that. We are continually sounding those areas as we're going through to see if there are any others we find along the way as we do the demolition. They are moving already. The contractors have mobilized, and demo began on 17th, so they're moving along nicely. Lastly, and not in the board book, is the fourth piece of this, which we kept the $4 million remaining from the other two projects in reserve on the $10 million, and that is the generator project. We have finally completed the study. The consultants have gone through and isolated every emergency and life safety circuit. We know exactly where they are, what bus they're hitting, what parallel gear they're hitting, where they're hitting on particular generators. We are very happy to announce we have a plan, and it is a very good plan. We can eliminate all of the old pre-1995 generators out of this and go entirely with the TXU generators with N+1. So we will be buying one additional generator that's 1.25 kilowatts, and that's a redundant backup. We already had money set aside to replace one of the existing ones. We'll reallocate all the wiring to those, and we will have whole house generator power if we ever lose power, which is not normal in a healthcare system, but it's exceptional. So we are very pleased about that. And that will get us through the next 10 years through the bond program and through the capital improvement program until we migrate out of these facilities. So very exciting stuff for us.
That's
And
great
it gets
news.
3 major issues out of the way.
That's great news. Congratulations on that progress, Adam.
Thank
I
you,
mean,
sir.
it's good to know that these chillers and generators that came over with Columbus are actually going to be leaving the facility now. And Adam, thanks for your leadership
And they're
on
leaving on the Nina, the Pinta.
that. And the Santa Maria, both.
Mr. Chair, I got a quick question.
Yes, sir.
So will the power generation capabilities that we're doing now, they will extend into whatever new facilities we have?
No, sir. This is only for the main side of the street. Conversely, what we're doing for the chillers will support the new behavioral health hospital, as well as the boiler plant that is there now. So we will be increasing the size of that plant. That's above grade. And that will take care of the PUC and the behavioral health hospital. And that's, in fact, on the site plan, so we can talk about that in a little bit. But that will save us money, investment dollars in the future.
Okay. When it comes to the projects that were, on one project we're over budget and then one project we're under budget, is it typical for staff to move those dollars if they're under the threshold, or do those changes need to come to us?
I'll defer to the staff on that.
I don't have any idea how much the money is, but,
So the board approved $10 million, and this is according to our capital person in finance, and she said that since all of that was allocated within that, she was able to move that. I'm happy to bring it forward to the board.
okay.
if we want to
No,
do
I was
that.
just curious.
Normally, if the board approves the overall project budget, you see increases in one.
And that's
decreases
what I
in the
wanted to
other.
make sure it wasn't.
That is correct.
If we go over the threshold, then it has to come back.
Yeah.
For this project. 3 million for that project, and they
No,
switched
when it
it.
goes over the threshold, we always bring
Okay,
them
all
right
right.
back.
Thank you.
Yes, sir. Any other questions?
Yeah,
Ralph, sure.
One is, I can barely hear you down here, so you
Yeah,
must be
we
really-
might adjust that, guys, just a little bit. Adam
Let
is
me make sure,
pretty
Adam,
hard to hear.
there is a color on the base of that. Don't ask me which one, but it's supposed to be green.
The
It's
green
green.
one.
It's green.
Okay.
I can tell his microphone's on, but there's an echo, and it's a little hard to hear.
On the chiller project, the neighborhood health clinics, are we addressing any issues with, because isn't there a chiller at the southeast facility?
I believe there is. There are chillers at every single one of our clinics. And we are replacing, I think one of them is on the list for capital this year, I believe.
This project, just take you guys back on memory for a second. It's been a long time since we've gone through this. You'll recall that staff last year brought us back a project that essentially was to address the issues that were here on the central campus that were associated with our chillers and our generators, that were really a combination of things, much of it just frankly being old and neglected and way out of sync with where they should have been, but a lot of it too with health safety issues. So the board appropriated $10 million to focus on the central plant issues that were in this building. Some of that was the concrete work that we talked about, Ralph, and the shoring up in the basement. But within that process, we approved the generators and chillers on this facility to be not only reviewed and analyzed to make sure that we were going to be replacing it with the right thing, because knowing that there would be some ability to carry over and carry forward new equipment into some of the new campus applications, but more importantly, get life safety issues back up to speed. So that $10 million didn't address any chillers or generators that were outside of the main campus facility. So capital project-wise, though, we do have some capital projects, I know, that have central plant issues in some of the other clinics. And so we might, Adam, we might bring that back
Yes, sir.
to the planning committee and give an update kind of on what that infrastructure update looks like for the other facilities.
And
Yes,
to,
sir.
to help you, Pastor, the other thing is, to Trent's point, the chiller that we had here was becoming a real safety problem, and that had to be addressed, we felt, immediately. In layman's terms, maybe to help you and me, because I need the help, when you're at a clinic, they're much smaller unit. This chiller
Right.
is the size of this room. So they do go out, but the luxury we have there is most of them, and Adam, you may correct me, are 1975 to now. The chiller that we had here was 1947, 1945. So the chillers that we have within the clinics came, when the clinics came on board, they're smaller.
Yeah, and I remember that history, okay? Reading I brought up stop 6, I said southeast, but really stop 6, is that I remember an agenda item where we talked about there was a problem with the chiller at stop 6.
The stop 6 chiller's problem is we have a problem keeping the copper. We had replaced it, and we
Okay.
were putting in new equipment out there, and we had 2 unfortunate thefts of the copper equipment, so we had to come back and redo and put in new copper. The system is now working, I believe, at stop 6 fine. We just had, when the vendor came out, they kept some of the copper visible, and it was not visible for long. It just didn't stay there.
So that's repaired.
Is that helpful, Pastor?
The same person that took the copper from stop 6 took it from my church too, so.
We wanted to be fair about it. We'll make sure they got everything.
Reverend, the reason I was hesitant to answer that, some of our clinics, we have rooftop units, some we have chillers, so I just don't recall all of them off the top of my head.
That answer your question? Right. Okay. Other questions for Adam concerning the infrastructure update? Okay, perfect. Then, Adam, let's move into the non-bond program-related capital regarding our parking garage RFQs for the new garage and the pavilion, please, sir.
All right, so as part of the non-bond work that actually are enabling projects for the bond program, one of those is a parking garage. As well as the parking garage, which we will talk about when we go through the master plan when Mr. Walls comes in here. There will be other enabling projects, temporary parking lots, et cetera. The parking garage itself, which you see up there in the corner, is actually roughly 8 stories, 2,600 cars in capacity. Underneath it, it's expected to house the future ASC. In other words, there will be speed ramps to the second floor, and they'll be 20 feet clear in the air by the time you get to the second floor. So that allows for an ambulatory care clinic to be on that property. It's the most visible, accessible property we have, as opposed to what was originally proposed, which was south of the pavilion, near the railroad tracks, and blocked by the Allen Street overpass. So,
Yeah, it's hard, it's really hard to hear.
I'm sorry.
Um,
Does that help?
Yeah, pull it closer to you, Adam. Maybe it'll be a little easier for us.
So what this does is this brings all the parking in one location for the entire campus, and it allows us eventually to tear down the Morphy Street garage, and it allows us to free up all the temporary spaces that we will build as we go through this. So for example, where the previous hospital was, which is the green site, we're going to build a temporary lot there so that we can tear down the Morphy Street garage. But in the interim, we'll be building the new garage. Once the new garage is built, then we can start on Tower 3 and 4 in the diagnostic and testing. So it is a step-by-step domino process. The same is true, and you'll hear this when we talk about, when Angie comes in and speaks about the outpatient behavioral outpatient building. When that is complete, then we can tear down the Hemp Hill building, which the board has already approved funds for in the past. When that's torn down, we'll have a temporary lot that we put in place there. which will service the behavioral health hospital, because we're going to take out surface parking when we start building that. So it is a domino process, and there are multiple running simultaneously as we do that. So we just wanted to let the board know that we are going out for an RFQ in order to do the parking garage as quickly as possible. We contemplate that to be a design-build project as opposed to a design-bid-build project. That way we can get it to market faster, we can build it faster, and we can get the parking issue out of the way permanently so that we can continue and progress through the bond program much more expeditiously.
What's the budget, Adam, that you're contemplating for the two garages?
The one garage, the one on Magnolia and Main is roughly $45 million. That's what we're seeing that as. It's 2,600 spaces. We're thinking it will be precast. We do not want to port in place. One of the architects we just spoke to recently said that they did a port in place garage, and it was $20,000 a space, and that's far in excess of what we want to spend on this garage. A port in place garage also would take an exorbitant amount of time because it has to happen floor by floor by floor by floor. Whether in the case of a precast, it can be poured off-site and then erected on-site much more quickly. We're hoping, if all goes according to plan and our scheduling, that we start construction on this sometime in the spring, which means we'd finish roughly a year later. So, pretty quick build.
Okay, how about the pavilion? What's the budget and the situation on the pavilion?
The pavilion is the yellow slot that you see just to the north of the pavilion. The entire, I'm going to have to switch to the other to show this.
Okay, go ahead. Sure. Turn it on. Nope, not yet. Hello, testing, 1, 2, 3.
Is there a button on the bottom of that?
Now it's live.
There you go.
There we go. So one of the components of the new replacement hospital is to fix the circulation issue within the hospital, both for our patients and the staff. And the notion of that is to can have a continuous spine of circulation all the way through. 2 separate corridors. In order to do that, we're going to have to relocate interventional radiology. That means it will move to the north. What this also contemplates is their dual corridor. So one corridor is all for staff and patients so that visitors are not looking at the patients as they're wheeling by. Directly adjacent to that is one for visitors. They would run for the full length and then connect through the Skybridge system that connects to all the service buildings in the back again. So we're keeping a separate process for our visitors versus our patients and respect our patients. So in moving interventional radiology to the north, that is one section of interventional radiology. Adjacent to that, interventional radiology has a corridor and rooms, procedure rooms that can ultimately, in the long run, convert to ORs, inpatient ORs. What this does is it also eliminates, and if any of you have driven by and seen this in the morning, frequently we have trucks that back into a loading dock here and block the ambulances from entering. That's an issue. This eliminates that altogether because, as you can see, there's a future ring road and all of the service docks are in the back. That also allows us to fix our trauma bays and expand the ER in the back, as well as, hopefully, and we'd still have to do a space count on this, is go ahead and move the endo rooms over with the ORs on the second floor. So finally, we'll have endo, the ORs, and IR all together in one place. Additionally, what it does, because it clears out some of the space that we have over here, which is recovery and procedure for the IRs, that gives more volume for pre and PACU for the ORs in the front. So it's a very economical way to do it. However, that said, out of everything that you see, that will be the most complicated project because it's similar to, I have 3 questions for you in 64 parts because it will be multiple phases. multiple migrations, multiple shutdowns. So we want to start on that early because it's going to take a long time to go through that project. We don't have a timeline for that yet. But that is critical for providing essentially a flat face and expansion joint so that when we build the rest of this, it joins up with the rest of the building and seamlessly integrates on that second floor and first floor. So we want to go out for RFQ for design on that. It will be a lengthy, lengthy design, at least a year of design work, minimum. So
the existing garage stays in place until the new garage is complete in terms of the main Magnolia?
this stays in place for the length. We haven't decided if we're going to eliminate this yet. The RFP contemplates building a garage for behavioral health, but since all of the main hospital will come down, I do not see a reason why we don't use that garage and repurpose that. That will save us money. We are also considering that this will stay as well because the behavioral health hospital will be separated over here. It may be in this location, it may be elsewhere in this parking lot. We don't know that yet. But if we have a materials management area here and a linen area here to service that, as well as on the other side, then we don't isolate the behavioral health hospital as much. Additionally, the behavioral health cup that I mentioned, we would expand and bring the electrical head in here and the emergency generators, add them onto that, and that will feed that, which it already is feeding TSP. Again, all of these are cost-saving ideas that will save us from spending capital in the future and taking on debt.
All right, so these two RFQs, do these require, Daphne, do we have to act on these or not?
No.
Okay, all right, these are information reports on the two RFQs that will be released. Adam, when do you see the RFQs hitting the street?
Within 60 days.
60 days, okay. Questions?
Yeah. You lost me about 3 hours ago.
Sorry about that.
And part of that is because of hearing you, but let me make sure I understand. The RFQs, we have two that's gonna go out, right?
Yes.
The RFQs will address the pink up here area?
No, sir, the yellow. This yellow area right here and this yellow area right here.
The new, okay. Wait, sorry again. Oh, okay, EROR right there.
Yes.
Okay. My question is then, that has not, how does that correlate with the bond program and parking garages?
So the bond program contemplated either raising or adding to the Morphy Street garage. The Morphy Street garage will not exist. That parking garage will not be in that location. That is not the ideal location because it intermixes staff traffic with service traffic and all the service trucks. And we're trying to finally rectify that on this campus.
And let me address that too, Ralph, because I had the same question and thought, and this will move a little bit into item 6B, so bear with me a second. The intention with all of this is that we have very clear programmatic management of all of these aspects of this entire project, right? We need to dispel the notion that even though we have separate funding relative to the capital projects and the bond projects, these are not independently running projects that do not have coordination and the program input from Broadus and all of the rest of our staff and our team. So while we have to separate them in terms of timing and in budget, don't believe that in any way creates a circumstance where we have this headed in one direction without the program oversight for the entire campus, because that's not the case. And we'll hear more about that when we get to item 6 a little bit later on. But I don't want anybody to get the feeling that because these are being, issued as RFQs, that they aren't still under the same management and programmatic umbrella of the thought process for the bond program.
Okay, yeah, okay. Then maybe I'll wait, because my question, Bernie, is, okay, if Broadus is, lack of a better term, our program manager, I guess my question is, I'm asking how involved are they participating with this in the RFQs and all of that? Are we doing all of that? I guess.
They're participating in all the RFQs.
Okay.
They are.
Their input is on all of these projects, right?
Yes, in fact, the RFQ that I'm going to bring to you for approval for acceptance of an architect, they actually did the matrix for that and sat in the interviews.
Okay, I'll wait for the next item.
Okay, and we will, we'll talk more about it, because part of this is not just the presentation of the plan. Part of it is the presentation regarding how the engagement of communication works on all of these aspects of it. And that's what I hope to address, Ralph, when we get to 6B.
Okay.
And Broadus will come in after that, and they're gonna make a presentation.
That's
as
where I
well.
was.
So
Okay.
kind of things to come. But again, in the effort to try to make sure that we don't get confused in terms of what's bond funding and what's otherwise, these RFQs are moving forward absent the bond program. So not absent the oversight of Broadus and their input.
Okay.
Yes, ma'am, Dorothy.
My question is on the traffic flow. Will this new garage and where we're putting it improve our traffic flow? Because that was a part of the overall, we were supposed to look at the traffic pattern and all of that. So it's,
Access and wayfinding was part of that initial
So
discussion.
part of Broadus's engagement is a traffic study. And so we are going out for the RFQ for the design of that garage. It's rough numbers until we know what that final traffic study is. So that's why we say 2,600 cars and 45 million. It may be less, it may be more, but certainly with us spilling onto Magnolia, that's going to improve what's going on Main Street. So I hope that answers the question.
I'm not sure it does.
Okay.
one of the specific questions that we wanted to address is whatever we did, it would improve the traffic flow and not have all this waiting and wrecks and stuff. So that was a part that I thought we looked at before. And we never heard anything on it. Well, let me say it this way. I did not hear anything on a traffic pattern and what they identified. Maybe I missed that meeting.
No, you didn't miss it.
No.
You didn't miss it. That the traffic impact analysis and the wayfinding was part of what we talked about, correct, Scott, over a year
Yes.
ago, easily, maybe almost 2 years ago.
Yeah.
And so, Adam, the question is, relative to the work that was done, and I believe we had a consulting study that was commissioned to go out and make sure that we had those access points identified. Has that information been incorporated into what you're talking about today?
Not at present. No, they're going out for another traffic study to do based on current loads. And I think just Shazo is their consultant on that.
Shazo's, okay. So then I think what would be a good idea is, once we have the overall traffic flow,
Yes.
wayfinding pattern from staff's perspective ready to be reviewed, I think that should come back to planning so that we can take a look, because everybody remembers going through that
Sure.
and saying, we need it, Lord, we need it tomorrow. So I think that would be a good one when it does get completed. And obviously, that's going to be integrated in with the overall project, but because it was identified before and because we went through the problem of this, setting up an RFQ, hiring a consultant, all that, let's bring that back and make sure everybody understands what that wayfinding looks like.
I think it would be best, Dorothy, if we brought that back to you, refreshed all of our memories on that, and never make the mistake, unfortunately, that JPS made years ago with the parking that we have now. We have cars coming in and pedestrians walking out, and the cars are going in front of where the pedestrians go. And we've unfortunately even joked about that we're a level 1 trauma center, and we have cars coming out where people are walking in front of. So none of that wants to be part of that. I think the best thing for us to do is take that study, compare it to where we are, because obviously in a 3-year period of time, flow has changed. We found that trucks are parking where they shouldn't. Things are different. Let's take that overlay and make sure that we present that to y'all, so we're not in 20 years being the folks that people laugh about and go, look where they put those cars and people.
I just wanted, that was my concern.
Yes, ma'am. It's ours too. And Pastor, another part that will help you with this, as we begin to plan as staff and we look at capital that we need for an ongoing basis that may not be an exact part of the bond package, we're very sensitive that when we talk about parking garages and other things that are need, that not everything go and be part of the bond package, because we want to be careful and not exceed our bond money and have to go back and ask for bond money when we have capital to make some of these improvements now. That would be ordinarily improvements that you would do as an organization. We've let a little bit of time go by overall where we should have been advancing parking or whatever as we expand and our populations expand. But that's why I think that the planning chair, Mr. Petty, wants to make sure that there's a separation, because part of this is just daily activity. But if we put it all under the bond, we would make a mistake, because we'd find out in a year or 2 years, oh my gosh, we're outspending our bond, and we're not going to go back to the citizens and say, by the way, can we have more bond money? So we want to be smart, and I think it will help if not only we distinguish that, but we let you and the others know that there's a lot of work going on to make sure that they're all coordinated, especially through Broadus and what we're doing.
Let's just go ahead and close Main Street and we can work all that.
I agree.
If you were still working with the city, that might be an option, but you're not.
We would all vote unanimously, I think. Does that answer your question, Ralph?
Whoever heard that comment, we are not asking to close Main Street down. Let me just repeat that.
The next article will start talking about, right?
I got one quick
Yes,
question.
sir, Roger.
You've heard, and it may be the first time I've heard it, that the building we're in now actually goes away?
Yes.
This building
This
will
building-
ultimately go away,
Yes.
as in
First
dust.
time I've heard that, and I just caught that in that presentation. So-
Yeah, it is the first time the board's ever discussed that. We've not had that update at all. And I think part of this process, and I'm going to do this now because I don't like it in 6B. I'm going to do it now. Daphne can throw a rock at me. Part of this entire process has been making sure that we create the right communication matrix between all of the individual parties that are working on this, the consultants, the staff, the board, and as you can all imagine, it has been a Herculean task. And I salute the staff for being very aggressive and moving forward, because we all read the paper today. I mean, there's a lot of concern about making sure we move forward judiciously, aggressively. And I salute the staff for doing that. As we do it, we have to have a matrix of communication and engagement to make sure that the board is receiving information and giving input at critical times before those decisions are made, and that we're getting information from our consulting staff on the right things to do and the efficiency measures that have to be done to do that. So if you all remember, when we wrote the Broadus contract, one of the provisions of the Broadus contract was that there would be an executive committee. And that executive committee was contemplated as members of staff and members of the board, not to be a majority of the board, but to be a small working group that would essentially serve as the communication link between the consulting staff, our staff, and ultimately the commissioners, so that we were clear that everybody knew what everybody was doing as we went forward. I had visited with Chuck and Robert last week a little bit about what that looked like, and we had talked about whether or not that was an ad hoc committee or whether it needed to be separately established. Daphne did some homework on that and looked, and since it is part of the existing contract, that executive committee can basically fulfill the same need that I was talking about in terms of making sure that we had that network of communication established. So what will happen with this executive committee essentially will be they will have to meet more regularly than the board, potentially monthly, potentially on an as-needed basis, much more frequently. So this would be the committee that essentially would hear things like you just heard, and there would then be a mechanism to bring that back to the board in sort of a cohesive manner that was clear to everyone how that sequence looked. So that's the plan. That's what we want to do. Broadus will be specifically engaged and a part of that committee. Mr. Early and his staff will be a part of that committee. I've volunteered to serve on that committee. Chuck and I talked about it a little bit yesterday, and Daphne and I talked about it today. I would request that the board consider Mr. Wynn, Mr. Bose, Mr. Montgomery, Mr. Fisher with me on that committee. to begin that work. And I've talked to everybody except Roger about that, and everybody is willing to do that. And that's not in any way to, try to put more work on that group, except they all agreed that they would be willing to serve in that capacity. I'm willing to serve in that capacity. So, obviously, all of our board meetings are always open to the board, but we don't want to get into quorum issues on this. So if the board is agreeable to that, within our existing contract, that executive committee will be established and will begin working immediately and reporting back to the entire board on an as-needed basis. And again, we don't know how often we're going to have to meet, but as projects come up, we're going to have to talk about those projects and bring them before. I tried to focus a little bit on the planning committee members, but this is a major project. I think every board member is certainly qualified and probably willing to serve on it, but also respect the fact that this is going to take a lot of time. And every board member is going to be extremely busy over the next 3 to 4 years on all of the different elements of the bond program. So that's what we would like for the board to consider. Moving forward, I've talked to the chairman, Dr. Weber. Do you have anything you want to add to that? That's our proposal, and I'm happy to take comments or questions on it. When Broadus comes in a few minutes, they will give an overview of where they are, schedule and project-wise, on the bond program, and we'll get to ask questions about that. But we don't want to be in a position of being on the receiving end of this information after decisions have been made. We need to be on the initiation side of these decisions with the expertise of the consultants and our staff and all the necessary places that we have to receive input. That needs to be done at a position where the board can still influence policy.
It's better to give than to receive.
Yes, it's better to give than to receive. But it's going to take a lot of time, and this is a big effort, and I appreciate those of you that are willing to put the extra time into this. You will see a much smoother, deliberate process and a more clear communication network as a result of the work of this committee. Because what I've basically told Mr. Early and the chair is from our perspective on planning, there should never be a case where we're not clear about what is going on with this project, how much money is being spent, and what the schedule is. And the schedule is the thing that everybody's concerned about right now. But, honestly, the worst thing we can do is charge the hill and not have the correct policy perspective and not make sure that we're getting the input of all of our experts as we move through this process and make a mistake that we cannot undo. So that's out of order. I'm sorry, Daphne. I'm happy to take questions, comments, observations about that. If any of you that I've talked to have said, no, I'm decided I'm not doing that, then speak now or forever hold your peace.
Before you all say you're not going to be on the committee, let me make a few comments. But I think part of the challenge.
Will there be cookies?
Yeah, there will be cookies.
There'll be cookies.
Part of the challenge that you have, and there's not a single person on the staff, and particularly myself, that won't want to inform you about everything in the community as well. There are so many moving parts, and people will say things that may not be a part of it. People will confuse parts of it. People will say this. We have internal problems. When we start talking about what we're going to build, I guarantee you there's going to be somebody in here that says, well, I thought you were building that first, because that's what concerns me. Tell Cheryl Hurd that we're not going to do this project, and she thought that was going to be first. She's going to be upset. Now I'm going to have another doctor upset. So I think I applaud Trent in trying to do this, because that's what we as staff want. Because y'all say, well, we don't hear from the staff. We didn't realize that was going on, or we don't want to be in that position. We also don't want to call you every second of every day. We know you have real lives too, but we want to strike that balance. Now, I am never in a position to correct any of you board members, ever. But I have to correct Mr. Petty because he left out one critical part of his description of the committee. He's chairing the committee, okay? He did not mention that part. So for the record, Suzanne, make sure that you get that in, because he conveniently left that out. But
We were going to draw straws.
No, we drew straws, and your straw was the best straw in the pack. So I do want to do that, and Roger, I think that will help you and the concerns that you or anybody else will have, or Ralph will have, saying, look, I'm a board member, I need to know what's going on. We want to strike that balance so, one, we don't live at your house, and two, you get the best information you can and dispel what is rumor, what is not true, what is true. Well, I didn't know we were demolishing this or doing that. Part of that is part of, even at this stage, preliminary plans as to what we do, but nothing comes out of this board unless y'all are informed. And Trent has just come up with, I think, is a great idea to help better inform with staff input and y'all's input. So I noticed that when he was talking, those of you that he called out your names that are going to be on the committee, not one of you made eye contact with him. But I hope that you all will be on that committee because it's hugely helpful for us.
And we'll also invite, if the county, if any of the county staff administration wants to be on that committee, then they're obviously welcome to be there as well. As long as we don't break any quorum rules, from our standpoint, the more the merrier, because this is really about making sure that we get and give good information at the correct time so that we can influence the policy moving forward, which is our job. That's what we're here for. Okay, any questions? Yes, sir.
Yeah, quick comment. So, I think the communication is great, and I think it's gonna be vital, especially to keep 11 board members, in line and what's going on, because this, we were largely, I don't wanna say in the dark, but COVID was a healthcare professional thing. And this is something altogether, so where the board, we may not have been as busy in the past year. I think we're gonna make up for it in the next 2 or 3, which I'm totally on board with. I think it's great. Is there any formal motion by the board to set up this committee? Is the committee set up?
It's already in the contract. So there was
Okay.
an executive committee provision
Okay.
in the original contract which brought us. This is basically just populating that committee and putting them to work.
Okay. And we're good as far as you're concerned, because you're supposed to keep us out of jail, and I don't want to go to jail.
She was the one. She was the one that told us what to do.
I won't make a good prisoner.
Yeah.
I promise. And I just want to make sure that, so that committee will be making decisions on behalf of the board?
No, that committee will hear information,
Okay,
bring information that is action item related back to the board.
Okay.
And that'll be, this committee will have only limited opportunity to make any decisions. We won't make decisions regarding where a building goes or what it looks like, our influence is going to be really if there's a communication problem.
okay,
Right? If one group hears one thing and one group hears another thing, our job is to make sure that we have connected those dots so that when the ultimate decision on spending money and putting contracts out, which all have to come back to the board.
Sure.
When they get there, there's a continuity of information associated with it, and there's board policy input that's reflected in that. So in no way is it intended
Okay.
to supplant.
yeah,
or replace the
that's
board.
my only concern, is I don't want to step on any other board member's feet
Yeah,
when it
no,
comes
we
to
don't
actually
have any
making a
authority
decision.
legally to make any decisions on that committee.
I
That
think
still
it's
has to
fine.
come back to the board.
Thank you. And I'm happy to serve because there'll be cookies.
My son didn't eat them all. He's here today, and we left him with the cookies.
I know, that was the problem.
All right, any other questions from this aspect of this? And I'm sorry I took it out of order, but it's just, people don't need to be in the dark. And I got to tell you, I feel a little bad. As chair of planning, I should have taken action quicker on this. I should have acted on this 6 months ago. And COVID and all the garbage that we were all dealing with, just, it didn't happen. But we're going to make it right now, and I count on each one of you to be there and be part of it, because I know you feel exactly the same way the staff does, that we can't get this done quick enough.
It's not an excuse, but COVID, this makes meetings so much more effective because it's easier to see diagrams, it's easier to have interface, it's easier to communicate. This will help a lot. This is kind of a historic day, in my opinion, to have us all back, and hopefully certainly up to you, Chair, of having our board meetings all back in this place, because I think it makes us a much more communication-oriented. The other thing is, when you are dealing with COVID, it is pretty consuming to staff, too. Karen's worrying about throughput and how many folks you have, and there's only so much bandwidth that somebody has to deal with all these issues when you're trying to figure out how you reduce 210 COVID patients in your hospital. So it makes it a lot easier now to have, one, better communication, 2, better understanding, and then 3, the overall where are we going and how do we distinguish it now that we're back.
And the chairman, Chuck, I've got to thank you. You have done such a great job of making sure that every single meeting we're recognizing the sacrifice and the work that our staff is doing during this COVID crisis. Every single one of us feel the same way, and thank you for voicing that as often as you have. Now it's time for us to take the next step, and we put that behind us. We move on. We give the citizens of Tarrant County and the patients of Tarrant County Hospital District what they deserve. And I think you're going to get a very sincere, genuine effort to make that happen.
Next board meeting is.
Good.
Super,
Good.
thank you.
But when you're looking at diagrams and maps, it's awful hard to do that on a Zoom meeting.
And it's hard to, you overspeak people too. It's so much easier when we're here.
And we can hear DT. stick the
Well, I don't
microphone.
know, I don't know we go that far, but.
All right, any questions on that discussion? Again, that's not an item I need you to vote on, just wanted to kind of get everybody's consensus on that. Okay, then we will move on to Angie. Where's Angie at? Is she coming in?
Outside.
Because we can't have a planning committee unless Angie talks to us.
Here she comes.
We made that a rule long time ago.
Yeah, we made that rule before any of us got here.
Angie, bring us up to speed on all of the regular work that's going on in the capital program management department.
Yes, sir. Thank you. So the routine capital I wanted to report on today, still exciting. We are renovating the building we own at 601 West Terrell, and that'll become our Behavioral Health Central Assessment Center. It'll relocate from its current location at 1617 Hemp Hill, which we call the Metro West Building. It is under construction. Postel is doing that construction for us. It will complete the end of June. We'll use July for commissioning and FF&E install. They're planned to move in on August 2nd and start seeing patients on August 9th. And I just would like to say that Postel is doing an excellent job. If you look at the pictures, that is an unoccupied building, and that is a really clean job site. So they're doing a really good job for us. Do y'all have any questions?
That's great.
Postel. It's one of our hub contractors, and they're doing super for us. Yes, sir?
Make a quick comment when you guys moving facility. A few weeks ago, I got a call from one of the,
Yeah, move your computer a little bit. There you
I
go.
got a call from one of the fertility specialists,
Okay.
and he's trying to refer patients to our OB.
Okay.
And every time that they call, the staff keep on telling them that the doctor are no longer there. So finally, I make that phone call, and it appears that they were correct. The doctor are not there, but they still with a claim. So they moved to a different building,
Okay.
but nobody tell the patient that they transferred to the woman's health
Okay.
and still part of a claim. So they technically were correct that the doctors are no longer there, but to the patient or other doctors, they got terminated.
DT, what if we reach out to Diana Prachel, and I make sure that we have a good communication when, we are moving buildings. I think we do notify our patients, but perhaps we can do a even better job.
I think the staff were correct, but they should be trained to transfer
Yes, sir.
or, be a little bit more helpful, but you can't blame them because they were technically correct.
Yeah.
The doctor is not in that building, but they didn't take the effort to locate and transfer them.
Okay. Noted.
Thank
Anything
you,
else?
DT.
Yeah, thank you.
Angie, what else do you have for us?
Well, I don't have anything else, but I will be bringing a couple of projects forward probably by the next planning meeting. When I get the contracts through legal, I'll be back.
Awesome, fantastic. Thank you, Angie. Good to see you.
You're welcome. Thank y'all.
All right, so now we're going to move into the bond project. And I know Derek is out there. Somebody want to ask Derek to come on in. Adam is going to start this off for us and give us sort of the 30,000-foot master facilities update. Everything that Adam is talking to you about also is reflected in Broadus's input. So everything involving the bond program, consider this as a team approach to begin to present how this information lays out. So Adam, kick us off, please, sir.
Well, I just want to say one thing about what Angie presented. Next planning meeting, we'll bring back the results for the enterprise-wide risk management, and we can show you what that capital planning effort is doing as well.
Okay.
So then that will speak to Roger's question about investment in the existing facilities.
Okay.
So it's pretty fascinating.
Yeah, just hold that thing close to you, Adam.
Okay.
And Derek, you may have to hold yours too when you start talking. 'cause we get-
So from the bond update, hello, Derek Walls. Broadus is now on board. The contract was approved by the board on 4/8. The behavioral health PKI analytics are on the way. Guidehouse meetings are underway, and the data request is being fulfilled as we speak. The master project schedule is nearing completion, and Broadus will present that today. We just spoke about the executive committee, and steering committees are being formed at the same time. Internal stakeholder meetings are already underway in the behavioral health venue. External stakeholder meetings are scheduled at some point to be determined. The RFQs, as you just saw, are here to discuss today. Functional space programming is set to commence very shortly, and master planning, we have a meeting next week to finalize this master plan with Broadus. So many fronts at one time.
Great.
Derek, go ahead.
Fantastic. Derek, welcome.
Yeah, thank you.
All of you probably know Derek. Derek is our on-site representative for Broadus and going to be a busy guy for the next several years.
Yes,
So
it's,
Derek, welcome. Good to be here and look forward to hearing from you.
thank you. It's very good to be here. And on behalf of the Broadus Levis team, just want to express our thanks for the opportunity, and we're very excited about it and looking forward to the challenge and are ready. I know we have a communication process, and Trent did a really good job of explaining that. I'm always available, but make sure we're going through the right channels doing that. Adam and I speak frequently, even if that's a Friday and a Saturday and maybe a Sunday. We've done that so far, and Robert has my cell phone, so we've talked a few times as well. So
I just need you to know that I've got 7 people on speed dial, and you've now moved up to slot 4. So there's a chance you're coming into 3, but once you beat my wife, you're going to have trouble. So
that's good to know. Thank you. So we're very excited for the opportunity. I do want to bring you up to speed on what Adam has just mentioned and the work that's already been taking place. We've got our consultant team. It's a large team. This is a very large project, so it requires a large team from Guidehouse, Price Waterhouse, Case Strategies is on board with us for our communications, Cumming for estimating and scheduling, and we have a host of other team members, and our hub MWBE participation is very important to us, and we have team members along the way that are helping even those large national firms like Guidehouse and PwC. We have local MWBE firms that are in place that are helping as well. So it's a great opportunity to help build capacity, and we're very excited about that. To take you through what we've been working on so far, and to address one of Dorothy's questions about the traffic study that was done prior, I think it was in 2019. Dunaway was the firm that did that work. Adam was correct. We haven't incorporated that yet, but we will. And we're going to use that information because we want to make sure, where we are right now, and we're getting ready to do a 24/7 traffic and parking study with staff on site 24/7 to help us with those calculations and making sure where we are, knowing that we could still be having some impact from COVID-19 with a number of people. So we want to definitely use that 2019 data to help support what we're doing now. So we will be bringing that in, and DeShazo is the traffic consulting firm, and we've been provided the Dunaway study, and we'll be incorporating that in. So that was one thing I wanted to mention. Along with that, we have other studies that are going on that don't sound exciting, but they're very critical to the project, which is geotech, what kind of soil conditions do we have, and things like that. So the traffic study, geotech, any environmental are things that they take time up front, but they're critical to the civil engineer, structural engineer as they get ready to start designing. So we want that information up front. So that work has already started. Again, I mentioned the planning effort. The planning effort will help ultimately develop the KPUs, the key planning units. How many beds, how many ED bays, how many OBS beds, those kind of things are what we're working through currently with the data from your discharge data that Guidehouse and PwC is working through. And that will be, we're working with your strategic planning team, your financial team already on that. That information then will come up to this executive committee that Trent's talked about. And one word that I've heard from Trent over and over is an iterative process, and it is a very iterative process. So please don't think that this is the broadest Levis design or this is the broadest Levis final. It's not. This is a very iterative process that we go through to hear feedback and help develop scenarios, and we'll bring those scenarios back to that executive team and whoever else we need to present to, and we'll work through. So it's your design, and it's what JPS needs, not something that we're developing on our own. So I want to make sure I understood that and it's clear. Behavioral health is moving forward with Zelia and her team for the PEC, the Psychiatric Emergency Center. That we've had ongoing meetings with the Meadows Institute, and that's been working very, very well with developing the information that's needed to help, again, get to the KPUs that will then feed the architect. The architect process, as Adam mentioned, we went through that and the selection of that firm, and that information will be brought to that architect to develop the program that, again, they will be incorporated into this executive level so that you hear what the size, the number of rooms, the number of bays, and the design components of that will be brought to that executive team. So again, that process has started, and we've been engaged on that for the last couple of months, and with Zelia and her team. The other one that's really on the cusp of starting is on the medical homes. We have 4 medical homes that are part of the bond program. We're ready to start engaging architect on that for the design, and the same similar process, but we have to select a site. Sites are not selected. So Buxton is part of our team. Buxton's been working with JPS for quite some time to help develop where those medical homes best fit in the community. And again, that will be a process that will be brought forward as we develop the medical homes. So that's very high on the priority list and what we're beginning to start working on.
Derek, these are all things that are going on concurrently.
Correct.
Everything you've mentioned so far is literally in process, right?
That's correct.
Okay.
Yes.
Because I know one of the things that we're going to want to make sure that we understand is if projects get prioritized for whatever reason, whether it's financial, whether it's structural, whatever, I think we need to make sure that the board understands that priority of schedule all the time. And if something changes in priority, we want to know it. We want to talk about it. We want to understand it. And you're going to need the board's, input on that, because that's one of the things that we're all conscious about is everybody wants everything today, but we also know we're not raising taxes. We know we're going to live within an existing, financial circumstance. And so that priority report is critical. And we want to be with you right there in the middle of that as you progress through that.
Okay. On the next page, the ambulatory surgery center, Adams mentioned that. We are in the process of getting ready to go out with an RFP or RFQ for the architect on that project. Again, we're going to go through our due diligence, the data analysis, how many ORs does it need? What other services might need to be put into that ASC? That's the analysis that our team, along with you, will be going through to develop what all needs to go into the ASC so it's right-sized and projects for the future, for future growth. I think probably the worst thing we can do is build something and not build it big enough, but we also don't want to overbuild. So with the data analysis, it'll help us really hone in on where you are now, where do you want to be, and where do we need to be in the future with the growth here in Tarrant County, which is growing every day.
Derek, I think to that point, and I think y'all are really good about this, and I know staff has worked hard at this, is when the pavilion was built 15 years ago or so, over time, there were some challenges with it. If you look at the design of the emergency room when it was built in a square-type fashion rather than maybe a semicircle, it made it more challenging for nurses' stations to be able to watch rooms that were in a linear design. And when they built the doors, they only put slits of glass on the doors so you couldn't see much. So a lot of the challenges from the nurses and the ED staff was this is a structural building that did not have as much input from the nurses and the people that are at bedside and using it. And I want to thank you at Broadus, and we're going to do a very good job, staff-wise, I know the board wants it, to make sure that our providers, clinicians, our nurses, or the end user realizes that that's the reason that is designed that way, or can you give us input so that that's helpful to be designed? The other thing, if I have any say in this project at all as we go on in the next 10 years or so, is if you are a patient, which I have been and maybe some of y'all have been, if you're in many of our rooms, particularly a room in the pavilion, the beautiful view you have outside your window is the back end of a heating and an air conditioning unit or something that looks as untidy and less helpful for a recovery process. Derek and I have already talked about when you look at something, what that means, whether it's a tree or green space or whatever. We want to be smart about doing that, and I want to applaud y'all from the very beginning of the need to include the providers and the clinicians and the end users, because we can get caught up, nothing against anybody who might be in the room who's an architect, is I don't want an architectural design that forgets the patient and forgets the clinicians who are using it. So just thank you for where you're going thus far, and the more inclusive we can be of the people that use it, the better off we're going to be.
Great.
And Derek, to that point, why don't you tell us how the user groups work and what that user group interface looks like to address what Robert's talking about,
Okay.
please.
I'll do that. The next page, it's a schedule, but it's a part of a schedule. And this was our first sort of look at here's an opportunity of how we could develop our communication. So what Trent's speaking to is we have stakeholder user groups and we have program subcommittee service lines. So that would be, I'm going to use Zilia, for example, because this is what we've been doing and what she's been doing and doing a very good job at. So Zilia and her team has appointed people within your staff that we need to reach out and talk to. We were on a call with Meadows this week, and I think they've reached out to about 75 staff. So what they're going to reach out for is some of it's survey type information, but we're going to be doing in-person interviews. So we want to hear what's working now and what are some challenges that you have now so that can help form what are the right adjacencies between departments need to be, what's the right flow, and then we're going to interject with what's a newer model of care, what do we see out nationally, and we're going to work all that in and include that staff at that level. Then from that subcommittee, that rolls up to the executive level. So the executive team will hear that, make sure that we're following what we said we were going to do and understanding the data and reaching out to those team members. But that's where they'll have input, again, at this level, where we're trying to develop the master plan. Then we bring the architect on board and we develop the detailed program, and then we again have user group meetings about the specific of the design. The beauty today versus when the pavilion was built is 3D modeling. We have the opportunity to go visit. We do mock-ups. We do a lot of work so that the end user has an opportunity to not only see it on a flat drawing, but they can actually put a hood on and walk into that space. And we've done that. It's fantastic. Did that down at Dell, I think it's like UT or some school down in Austin. I'm not sure which school that is. But we did that and had surgeons, with those hoods on, and they are literally grabbing, like you would imagine in a game, pulling the bed closer, moving the monitor up, moving the light. So that's the technology that we have today. We did not have that when we were working on the pavilion many years ago, but that's what the architect's going to be able to provide, and so your staff will feel much more comfortable and at ease when they walk into a space when it's built, and you don't want them to say, I didn't think it was going to look like this. So when we get to that next level of design, that's what we will help manage the RFP that goes out and things to make sure that that architect and that contractor and all the engineers are working on that BIM model, and that's going to be all part of the specifications that we have, so it's a very interactive process. Trent did a good job, very good job of explaining the executive committee, and I don't want to spend too much time on that. The overall schedule, we are moving forward, like I said, with behavioral health, getting the architect on board, and getting them working on the KPUs. The goal, or the programming, the goal that Adam and I have been talking about was to be able to start moving dirt on that project in the spring of next year. So to some people, that may seem like a really short amount of time. To others, it's going to seem like a long time. So we've got to go through what we're developing now. We go through the design process, then we go through the bid process, and then we can get the contractor on board, and that's when we see dirt moving.
I got a question when you were talking about planning for the future and future growth and how, Tarrant County, Fort Worth grows every day. I've never seen a hospital that we haven't added to. I haven't never seen a road that we haven't expanded. So is that a bunch of hooey to make us feel good, or how scientific and precise are those growth models? Because I can tell you right now, I don't think you're going to be building any of these things big enough, even with the models. That's just my personal perspective.
Right. So a couple of things with that is providing flexibility. So if we need to provide shell space, that's one thing. The other would be a more flexible model, and I'm going to use the patient room, for example, and Adam and I've talked about this too. Given if we were back here, say a year ago, we would be needing more ICU beds. So having a more flexible model so we could flex that med-surg bed to an ICU bed is what we need to build into the chassis, is more flexibility to help with that, but also where is our next empty chair, where is our next addition. If you don't plan those things now, you're right. If you think that you're not going to grow or things are not going to change, it's a big mistake. So upper floors, for example, may have a floor or two of shell space that's ready to go. Many projects, sometimes we're already building out the shell space before we even finish. So if we think that we're going to be able to project past, say, 5 years, you hear 10-year master plans.
Yeah, it doesn't
No.
work.
And the other beauty of this is having a team with Guidehouse, PwC, and all those team members. We're going to come back and revisit this. So we may not be ready to build a new patient tower, for example. That may be 2 or 3 years away. But we've got the team that's going to update the model and be able to project better 2 or 3 years from now than we could today.
Well, please, from my perspective, let's not short size anything because the consultants won't be here, in 10 years, and I won't be here in 10 years, and whatever else. But somebody, well, why didn't they think about this 10 years ago? So that's, they always say, okay, we'll put an extra 10% on the budget. Well, put an extra 10% for the size. That's what I'm saying.
Roger, one of the things that Trent keeps using a word called iterative, and I like that word, because we're not going to build this all at one time. We couldn't even do it if we wanted to. We don't have the ability. There's no space. We couldn't do it. That gives us possibilities of updating the model continually through the 10-year period. Yes, there's shell space in each of the 3 towers contemplated now. 5 floors, 200 beds of future shell space. That's contemplated. Again, I think Derek said it well, and we talked about this. At one point in time, there was a notion of a universal patient room. That failed miserably in healthcare. But now, flex rooms are where healthcare is going, where you build to an MICU model, medical ICU, and it can flex down to med-surg, it can flex up to ICU, and all the rooms are negative air pressure. Right now, we're talking about an entire tower of that.
Okay, good.
So we'd never be in the situation we are in right now.
Zim, you had a question?
More of a comment than a question. I know what Roger's trying to say, but we need to be careful. You can overplan too. And then you wind up with a whole bunch of empty space sitting around that isn't used. The computer modeling is more of a tool to make sure that the effective area you're looking at will be utilized correctly. In the aeronautical engineering world that I came from, we use that for maintenance to see if we put a box here, could that maintenance guy really do the job that was with that? And it's very, very effective at making sure that the utilization is correct, so.
Yeah, great point. And I think, that's one of the things the board has talked continuously about is let's not just do it. Let's do it right and let's do it efficiently. One of the components that you all remember that was part of the broadest RFP was matching up our growth of the system and the facilities with the financial capacity to serve and operate those systems. And that's a huge piece of this. And as we go through this, one of the things we're all going to have to be continuously focused on is what are the additional revenue stream possibilities that emerge from this design that give us the ability to start backfilling some of this space between cost and demand. Because we know that the operating costs are going to be gigantic with this facility. So part of that whole process was making sure there was a contractual component in this design that addressed that financial issue. And so I think it's going to be critical, Derek, and especially that, and obviously Sharon's going to be reporting through Steve and the Finance Committee on this, but this has to be done holistically in a manner that says, yes, we can build this. Yes, this is the most efficient and flexible design. And yes, this is how we pay for it, from when, using what, where, and how. And so that's a huge part of what we're going to be managing. Otherwise, we will, to all my friends across the Trinity River, we love you very much, but we don't want a Parkland situation.
And one of the things, if you think back to where we were 2 or 3 years ago, if we'd have done design decisions then, they would have not met the reality of today.
Exactly.
So it's important that you understand there's a dynamic here that you cannot plan for to the finite nth degree. And so, yeah, you'll add on another lane of road somewhere along the line, or maybe there'll be flying cars by then, I don't know. But the point we really is brought home by the pandemic that, gee, we really changed the way we do business, not just in the hospital business, but in all business.
Yeah, absolutely.
Yeah, one other thing that I was asked, that we've talked about throughout this program and also in taking our time with it, is the use of technology, is the use
Pull your
of,
mic a little bit closer, Amanda, thank you.
with the use of technology and really understanding what telemedicine, and we just went through that with COVID, and how that's enhancing within. Which of these organizations is looking at that also, your partners? They're looking at how are we taking medical units, the medical ICUs, pulling them through, and also taking into the consideration the fact that we're a teaching hospital as well, of how that utilization of technology, talking to the end users, not only about building space, but also the way that they use technology within those spaces. So.
Right, so we've got a technology consultant on our team, Protect. They'll focus on the technology, but it's also hearing from your staff, the importance of what is meaningful to a patient, but my opinion, more importantly is what's important to the staff here. And so what can make their job not just easier, but more effective. And there is emerging technology all the time. That's going to come from Protect. It'll help with how do we connect and make sure that this is going to seem like one seamless building, not multiple buildings. That technology doesn't work well. But when it comes to how we go about the telehealth component, that's going to come from our Guidehouse team, our PwC team, because could it mean a reduction of beds? Possibly. Could it mean addition of space that might be needed for a telehealth doctor out in the community? Probably. So those are things that will be analyzed from an operational perspective, but then to what Trent was saying, how much does it cost? There are things that we're going to be looking at, and to kind of speak to what Robert, and I don't like picking on the pavilion building, and he won't like hearing this, but early on, the flex beds were part of that design, so that you could have flexed beds from med-surg to ICU, and that got value engineered out.
Now,
If
Robert
you
didn't
call it
value
value,
engineer that out, just to protect Robert. Robert didn't value engineer that out. That was
No.
the previous administration.
Sure, yes, I knew Robert would kind of probably understand what I was talking about when he
And
would
that
mention.
previous administration allowed developers to spit in the salad, because boy, did they make everybody mad.
Right. So those are things that we're going to look at the dollar value of it. Maybe it's going to cost a little more money up front, but there's tremendous value. So that's why I'm saying it's going to be part your staff and our several members of our staff that can help determine what is the technology, how much it's going to cost, what can we utilize now, and then give us the roadmap for future technology.
Great.
The last slide, I don't need to spend much time on. It's more on the overall schedule of what we're working on from a master plan side of things. So we talked about the PEC, the ASC, medical home. So these are what kind of fits in our master planning schedule for where we're going to go through our programming and all of our data analysis. What we did do is the original RFP for us was focus on planning and master planning in the first phase of the project. We're moving forward with that with some implementation like behavioral health, medical home, and some other components like the ASC. Instead of waiting till the end of the year, we're starting some of that now. So that helps expedite the schedule. But this is our overall plan where our team and your team are going to be working over the next year.
All right. Any other questions for Derek? Observations?
Yeah.
Yes, sir.
Derek, let me see how I can get this out. You explained and shared about the total master plan, putting together a master plan. Okay. As you're putting together that master plan and the overall program for the bond program, are you recommending priorities, or are you getting those priorities from board and staff? I have a two-part question. And the other part is, how integral are you, JPS, Adam, in discussion as you go forward to put the master plan together? Because there are some things we received today from Adam, and my question is, are you at the table, and both of you at the table, discussing and reviewing that before it comes to the table? Because I just heard a second ago, it was news to me, that this building goes away. That's new to me. The other is, I know that there's a cry in the community, or it came from Blue Ribbon or commissioners in reference to behavioral health. But I know when I talk to folk, pulpit and streets, we talked about bed tower. So how do you, I'm raising my question now, how do I justify that? And then I got Dorothy at the end of the table who want an ambulatory center. So, yes. So I'm just wondering how.
It's here.
How is that mix taking place so that when we hear a presentation here, we know all is on one accord?
Right. So we are working in one accord with Adam. We are continuing to develop the master plan. There's opportunities for shift and change. You know, when you look at that map and you say, well, that's where the PEC and the behavioral health tower is going to go, that's not exactly where it's going to go. It's not the exact size. That's part of this process that we're going through currently. So it's really, a lot of it's data-driven and information-driven to help develop what needs to go in and what size it's going to be. And then there are factors that are going to tell us where it needs to go. And then when it comes to schedule, there are some things that are enabling projects and things that we can do now, things that may need to wait. I'm saying from a construction standpoint, there's some physical things like Adam was mentioning, the work in the pavilion building. We can't start on the east side of the campus until we get that pavilion work for much further along. So there's some things that are sort of schedule and data driven, but we need to hear back from this team and the input on prioritization, and we also have to look at, you know, how the money gets outlaid, and we can't do everything all up front. And so those are things that we are working through. We are working on these projects simultaneously. So we're working on medical home, we're working on the behavioral health tower. So some work is going to happen simultaneously. We have to be a little careful on the main campus because this campus, because it's so active, we have to be careful about how much activity. You know, Roger knows if we brought in 500 construction workers, what kind of impact is that going to have on this campus from lay down yard, construction workers, parking, all. There's some of that, but we need to hear back from this team, and Trent maybe can help me with that, on making sure we've got the right priority of where these things fit on a schedule.
I think that's a crucial question, and Ralph, at this moment, I don't think anybody knows the exact priority, because what we have to be able to do is take conceptual information that's accompanied by conceptual cost estimate, bring it back to the board, and let the board have input on those conceptual ideas. Because the intent is not to say, we're gonna go from concept to RFP to design to contract and then tell the board what the contract says. That is not gonna work. We have to have conceptual input because this prioritization process has to have policy input. It has to have. And the intention is to make sure that the system that we're designing accounts for that and that we provide it early on in the process.
Especially around the parking and all that stuff also as well. Because that's the first impression of the patient is the parking lot, right? It doesn't matter how nice the building is or can you kind of give us the conceptions of what would it look like? Because we want to build something so that the flow of the traffic, you know, share ride apps, buses and the flow and all that stuff in and out. I kind of like when I saw Toyota's building the city of the future. Mm-hmm. And I'd like to see what would we envision 10, 20 years from now, and how things change. And I mean, because any movement or parking can delay, and we have clinicians waiting. It's very costly if they can't find a parking space. Or is it too big, like Costco parking, or is it too small that you can't fit any trucks in here? So those are some of the things I kind of like to see the flow a little bit conceptual.
Sure.
That way, because it won't come out in the RFP or any of that stuff.
Right.
And by that time, it's too late for us to give any input on that. And now we're stuck with the building, but we don't know what to do with traffic flow and parking.
Right, so how I would address that too is we will be building a model, and we'll probably have maybe 4 options of here's how this could work, and then we'll be bringing that back, so you will have input. There's certain givens in parking, but at the same time, we can develop a model where you really feel as though you're in that space. And I was with an architect just the other day that showed me an image, and I thought it was real. It wasn't. It was virtual, but it's a way that we can better communicate so that when you're looking at parking, and then our traffic study, our flow diagrams can tell us during those peak times how many entrances to that parking garage do we need to have, and where's the traffic coming from. So the traffic study and then the design will impact what that eventual layout looks like, and we'll be able to bring that to you.
And kind of a follow-up to Reverend Emerson, in the communication, this weekend, it was revealed to me that the Phase 1 plans of the bond program have been released on Facebook. And it's pretty close to that map, a little more rudimentary, but as you said, where that building is shown, that building may not go there. I want this to be a very public display, and certainly appreciate the public's, information, but maybe if we put that out there, hey, what do y'all think? Instead of Phase 1 has been revealed, because I was like, oh, I guess we'll learn about that on Wednesday at the meeting. But certainly when we put out something that is a declaration, then let's make sure that that's what is going to be what, because it'll cause a whole lot of questions, going back to your point, Reverend. So.
And if it's the same article, sorry.
No, go ahead, Derek.
If it's the same article, it said something about Broadus Levis provided that. We didn't provide that, so we have to be careful with.
Yeah, this drawing, although close to that one, does not look like that one,
Yeah.
so I believe that.
And a little bit of an offshoot to that, Roger, and this is a little bit of a challenge. Before the bond package was passed, we as a board and staff met, and we had the understanding that as board members and staff, we weren't going to have individual discussions with people, because that's what led to a lot of what you just brought up. I don't want to restrict anybody from information, but you all as community leaders, our county commissioners, and Roderick, thank you for being here. It's not like you don't have enough meetings to go to. So Roderick is with Commissioner Brooks's office, and I'm thankful that you're here. One of the things that we want to do is try to not have staff meeting individually with developers and contractors, and you all are going to get a lot of phone calls, and Zim's going to get a call, and they're going to say, hey, I need to meet with Robert Early, and I need to tell him about my project. 2 things happen that make that go awry, and Daphne and I have talked about this, is when you do go out for the RFP and the RFQ, somebody can make the accusation, I've already met with Robert Early, and he suggested, okay, then I'm not being fair to the other developers and contractors. So I don't want to come across as me, Robert Early, or staff, or you as board members not being fair, but at the same time, I think we ought to go back and revisit the same rules we had pre-bond, and that was you as board members and certainly us as staff, ask them if they would like to know how to bid or any information. We'll provide them the information on the process. But to have an individual meeting with individual contractors and developers or anybody else who would be a part of the bond really presents a problem. And that's why I'm glad you brought that up, Roger, because some of that information can get out in different ways. And I think that can be a challenge at times, not that information per se, because I think there was a need to let people know some things. But somebody says, well, we want to do this, and somebody said, well, I think they're doing that on the corner over here. And then all of a sudden, it's part of information that may not be correct, or we may be giving unfair information to somebody, either way. So I'm going to tell you all, as staff, we have asked the staff not to have individual meetings with contractors and developers, just to be fair to everyone.
Robert, if I could just say one thing. I had the pleasure of chairing this board for 2 years during that bond package and the year afterwards. and how many calls did we get? But we think that was back 3 years ago. As Trent knows, I had a call this week from someone here in town who said, Charlie, we're hearing this. And I immediately said, no, I don't discuss that. I referred him straight to Trent instead of planning, because I felt like he'd be the point person. But, I mean, even it just continues on. I mean, we've had 3 years, this even prior to the passage of the bond, and we're all excited about we passed the bond. But I think everybody is getting the point in time, like the article, that what is going to happen. I think that even fuels more people trying to call. So I think that's the way to handle it.
And I'm not responding to any, I mean, I'm getting calls, I know you guys are getting calls, I'm not responding to any of those. I mean, it's just not an appropriate place for us as board members to be inserted, and ultimately it's gonna get, somebody in trouble. So, good point. All right, Derek, does that conclude your comprehensive plan remarks and kind of the overall schedule and priorities for Broadus? Okay. Then let's move into behavioral health. Adam, you're going to give us the information relative to Beck architecture and the behavioral health design.
Yes, sir. So in conjunction with the schedule that Broadus presented, the behavioral health component is first on their schedule. So we went out for bid for design and functional space programming for the PEC and the behavioral health hospital. We had 12 respondents. Not surprisingly, all the large-scale firms responded. Beck, Canon, GH2, HTR, HGA, HKS, Hoffler-Welker, Hewitt Zollers, Page, Perkins, and RTKL. It was not surprising that we got that. It's a big project. Derek actually sat on that selection committee with us as a non-voting member. He put together the matrix for all of the respondents. It was a great matrix, and it helped us tremendously. Every single one of the respondents exceeded our 25% threshold in HUB participation. Ultimately, the individuals on that selection committee voted separately, and the leading vote getter was Beck, and we invited 3 firms to come back and interview with us. And again, Beck was the selected firm out of that. Beck has a local Tarrant County office, and I do agree with Derek on that from an optics standpoint, that is very important. And they are certainly an exceptional firm, and they are aligning with Gensler to do this. So the horsepower is certainly there.
You're aligning with whom?
Gensler. They're an international firm, very large.
So remind us the scope that Beck is going to be doing on the project.
Functional master planning, functional space programming, and design for the PEC and the hospital.
Okay. So this is the behavioral health component.
That's that behavioral health component.
Zelia's in the back, if anybody has any questions as well for her.
She sat on the committee, as well as several of her folks sat on that committee. It was very behavioral health centric. And we've already met with them once just to get an idea of what they're thinking for the Central Utility Plant. So they did that gratis to start the process.
Any questions on this recommendation?
I got a quick one. How does Beck Architecture interact with Beck Construction? Are they one and the same?
Interact, Beck Architect and Beck Construction, are they one of the same?
They can be if they do a design-build project, but in this case, it's purely architecture.
Okay.
So it'll be a separate construction contract?
Yes, this is an IGMP contract.
Right.
So.
The only thing I would add is they also had a behavioral health consultant, Architecture Plus. They're a very well-known national firm. They've worked with Zelia and other projects, and so that was a very strong component of that team and a few other teams. But from a design and thinking of patient flow and things like that, having Architecture Plus is very, very strong.
Are you going to bring that packet? Will the board get a chance to see this firm and the background of this firm and facilities they've already done?
The contract will have to come back to the board.
That's
for
correct.
approval.
Yes.
So that, whatever level of detail, Ralph, we need to include in that, we will.
Okay, well, okay. I guess what I'm asking is, what you reviewed, I'd like to review. What you saw to make a decision, I'd like to see that.
You had how many firms?
12.
No, I'm not asking for the 12.
A minute, you don't want that.
No, I had that when we selected broad.
Right, exactly. We've been down that road.
I mean, but that packet that what they submitted that made that final decision to select back.
Sure.
Oh, their proposal?
Yeah, we're happy to share that.
We can do that, no problem.
Those are all public records, so we're happy to share that.
Pardon?
They're all public record. Of course, we're happy to share that with anyone who wants to see it.
Yeah, we can make that part of the portal.
Yep.
Digitally and make sure board members have access to review that.
I think are you asking to look at their criteria? These are the things that they valued, they
Yes.
rated them on.
Right.
And they will have some a backup document
Backup,
showing that.
right.
Oh, okay.
Yes, sir.
Yeah, all right. Yeah, and part of that will be looking at that, their compliance with the WVM.
Absolutely.
Yeah, okay.
25%.
You bet.
Who are those? Are they all
That's
from out of state? Okay.
And I think it's a good point, and we just establishing protocol, right? These are precedent-setting decisions that we're making right now. So what we should probably think about doing is every ultimate RFP that ends up in a recommendation from staff and Broadus that ends up before the board should have the recommended entity with their full packet, their proposal, their MWBE, their criteria, their scope. That needs to be available for every board member to look at prior to the board voting on it.
Yeah, thank you.
Yes, sir.
I guess my concern too is, it's good to hear you say they're a well-known firm, they've done many projects. I just like to see some of those projects. I just, just to see their end product in other places.
That is in their proposal, and they do quite a bit of work for Parkland as well, so it's local as well.
But I think your point's well taken, whatever it is, whoever it is, you ought to have the ability to see if it's available, even virtually, to see what they've done, to see what it looks like. I think that's more than fair.
Yep.
Okay.
All right. Anything else on behavioral? So Daphne, do we need to have a motion on that or not? Does that just go straight to the board? Or do we need to make a motion on planning? I think we're looking for approval. Okay, all right, so this is an action item. Ralph, are you comfortable with that?
Yeah, I just, one more question.
Yeah, sure, of course.
That's why I asked the question earlier to Derek, and really I guess I'm asking that to the planning committee and the board. We're getting ready to vote on something that's in relation to the bond.
Yes, sir.
Okay, behavioral health. Where did we rank that behavioral health is the #1 item? How do we get to this point of saying we want to roll this out and take these steps and as we look at the master plan?
I can tell you my answer to that question. There may be other answers. When this first began, from commissioners to staff, there was sort of a unified voice that says behavioral health is our biggest crisis. We're in more trouble there than any place else just because of the facility issues that we had. And so I'm not sure if it was a board vote that said behavioral health is #1, as much as it has just been sort of the evolution of that idea from day one. Ralph, is that a fair assessment?
It's very fair, and I think the other part of that, Reverend, is when we were providing tours to the Blue Ribbon Committee, the thing that stood out the most to a cross-section of citizens and individuals was the challenges we had on our 10th floor and the really, really tough situation. So I don't think it was really a situation where anybody said, okay, this is #1 priority, here's where we're moving. We've analyzed 1, 2, 3, and 4, because a lot of the bond is almost not going to fit into a 1, 2, 3, and 4 category. It's going to be, let's move forward. This one was from what we heard from the community, what we heard from our elected officials, and what we know is a challenge of having an emergency room for behavioral patients on a 10th floor, that's really where we put an emphasis that we thought we would have the greatest impact from day one. And day two, we hope, is really quickly following day one, if that helps.
Yeah,
If I'm not mistaken, Ralph, one of those was an operational issue. We had major problems with those patients going up to the 10th floor. And so it was a high operational problem for us. And the other deal is behavior health was one of those areas that the community had so much concern with. So I don't think we ever voted on it, but behavior health has always been there. And the second piece of that for me was the operational piece, that taking the patient to that 10th floor, because I remember that patient coming, that family member coming and saying how it was to get her family on that elevator and all of that. So it was more of an operational issue for me.
yeah. And I don't argue or dispute that. That's not my concern issue, because I understand all of that conversation, okay? I guess somewhere, I think we as a board should have taken a position. I think we should have said I think as opposed to us talking around the table, I think it should have been said someplace that this is how we're gonna move in this particular area. Because as we're talking now, I think it's just kind of an assumption. But we, as a board, never took a position that we're gonna move this way. I know, I sat at the Blue Ribbon, and then when we had the big meeting, and behavioral health was on top out there. So, you know, you can see that's coming, but that's what I'm asking. Did we ever say anything as a board? Did we ever take a position? You know, and I don't think we did, so.
No, you're right, you're right, you're absolutely right.
Point made.
Question.
Yes, sir.
I couldn't find my planning stuff in here, but I looked at his. I'm really concerned that we're being asked to approve a contract that we haven't seen any of the general detail information about price, anything else like that. Plus, I always like to see not only that, but I like to see at least the next candidate. And then I'm curious, what is the criteria that we use when we're making the selection? Do we have a numbering system, a point system?
Yep, that's a great question. And I think there's enough concern, legitimate concern, about process, and this is again our first one, so we're learning lessons here. We probably need to bring this to the full board. Let's put off a vote today from planning, but let's prepare it for the full board and make sure that we have the portal populated with the information that you're being asked about right now. There's no reason this has to be done today.
Right.
It needs to be done where the board is confident and that you've seen the information, that you're comfortable with the information. So let's populate the portal with this information and put it on the next board agenda.
Yes, sir.
If it can be made ready. Can we get it done that fast? Zelia, everybody good with that?
We could do that.
Okay, then let's hold it off today
on
then,
there now.
and make sure that that information is available for everybody to look at and peruse. And that way, when questions come up, everybody's got the documentation in front of them.
I think
Yeah, Mr. Chairman, can I make a formal motion to table that to the 10th?
Yes, sir, you absolutely can. I've got a motion
Motion
from
to
Roger to
chair.
table, second from Zim. Any question or discussion? All in favor say aye. Okay, so look for that
We'll see it this next Thursday.
coming attractions.
Yeah.
And I'm with the entire board will see it.
Right.
And I think 1 week will not delay. I think we all are committed to get these
Right.
projects, whatever the board decides, Ralph, I'm with you. But a week shouldn't delay.
You would have had it on the full board meeting
Anyway.
anyway as a
That's
consent
correct.
item.
Just
We're
let them
pulling
all
it
have
out
this-
now, so you have the time to look at it. And Zim, what you can do to help us is when you pull it up on your portal, if there's something in there that you feel anybody wants more information on, please communicate it to us as staff, because we won't know what you've seen or not seen or pulled up or would want more on.
I think it will help one way, is that you will finally have a process of looking at these bids.
Yeah.
Because the criteria is something that should be pretty clear.
Sure.
This is what we're looking for, and these are how the folks fell out. I mean, that rating system is part of that Angie used to bring with construction projects, but nobody else ever brought it. So I think that is one of the ways that this really will help us get that in place. You'll see that, and then you'll be able to look at it.
Commend the staff bringing it to here. I think the reality is that 10 of our 11 board members have been here.
Yeah.
We now have our homework to be prepared to come next Thursday to that meeting and hopefully move things and answer the questions we need to answer.
Completely fair, and let's make sure the scoring criteria is in that packet.
Yeah, the reason I asked the question is in reviewing other proposals for contracts on the city council, one of the criteria was, have we done business with the city before? And it got abnormally weighted so that a newcomer didn't have a chance. So,
Well, I think everybody needs to understand that criteria, and if there's questions about it, we need to ask.
Mr.
Yes.
Again, this won't be for the full contract. That has not been negotiated with them yet. This is just for the selection of the firm. That will come later at the next finance committee meeting.
Everybody understands that, right? This is about who you move forward with to solicit a contract. So
we all understand that. The question was, what was the process that you got to get here?
Right. Okay, exactly. All right, very good. So that item is tabled. Thank you, Mr. Fisher. Community Health Medical Home, RFQ. Adam.
So we just
There's a
wanted to-
pattern emerging here. I think everybody kind of sees it.
Yes.
So be prepared.
So we are informing the planning committee that we'd like to release the RFQ for the community health medical home, as well as the ambulatory surgery center that Derek showed on his presentation.
So this is to release the RFQ?
This is just to inform the planning committee that we will be releasing within the next 60 days.
So the RFQ has it been constructed in terms of, has Broadus been involved in that? Tell us what's happening.
It's coming in the next 60 days. We will release. We're still in that process.
Okay. All right. So the action you're asking planning committee to take today is what?
Nothing. It's
Just
just to
telling us that
inform
you
you.
are moving forward.
Informational.
All right. Informational item only, moving forward with preparation of RFQ on both these items, right?
Yes, sir.
Okay. Any questions about that?
Let me make sure where Reverend is, because I've been with him long enough so I can read his face without even turning my head. So, Reverend, because I don't know if you heard Adam, because that mic was far enough, or tell me how comfortable you are with what he presented so that you understand and I understand where we are and what that is.
Well, to be honest, part of it I couldn't even hear what he said.
Right.
The other part I understood when Trent asked, were they connected? Derek shook his head.
Okay.
No. You guys were not
We-
involved in the RFQ.
Not yet. So what we've talked about in our meetings is the schedule of, we need to get the RFQ ready.
Yes.
And then we work with Adam and his team in developing that document. So that part hasn't started yet, but we have been talking about the schedule of getting that RFQ out.
Okay. So what you're telling us today is you all are going to begin working together to prepare an RFQ that will ultimately come back to the planning committee and get action to move forward, right?
Correct.
Okay, because I think what you're hearing, there's a pattern here, guys. Understand it. When there's going to be an RFQ presented, the board needs to know what that RFQ is for, what purpose, what project, right? The board's perspective on that RFQ needs to be heard. We don't want to assume that it's okay to move forward on a project, tell the board after the fact that we've done an RFQ. We need to bring the RFQ to the board so they can understand the criteria, they can understand the scope that's being solicited, and we can understand schedule. So that's what I hope you're hearing for RFQs going forward. Is that, am I wrong, board? Is that accurate?
Where does your executive committee fit into that?
Well, I don't think it necessarily does unless there is a problem or an issue that needs to be resolved and there's internal conflict that we got to fix before it comes back to the board. Again, the executive committee is not approving anything.
Right.
The executive committee is gonna hear the issues, make sure it's packaged properly, brought to the board for final decision. But you've got a very engaged and interested board here, guys. They need to be a part of what's going on. So when we're at a point where we're willing to release an RFQ, here's what it's saying. First of all, it's saying, we're ready to move forward on that project. Well, you've already heard today that there needs to be board solicitation and input on what the priority of projects are, including what we go out for RFPs for. We don't need to assume that the steps that the staff is taking relative to the projects we're pursuing is a fait accompli. That needs board input, because that's where the prioritization process gives the board an opportunity to have input. Then the board needs to understand the scope of the RFQ. What is the intention going to be relative to what that project is? And then the board will tell you, hey, look, yeah, we agree. It's time to get that RFQ on the street, but we haven't seen it. We don't have anything to look at. We're gonna have to have data and information to be able to move forward on that. Does that make sense?
Where does the
Yes.
strategic planning folks fit into this?
Well, the strategic plan part is going to be an overall direction. So what you're gonna get when you see programs like this, if staff is doing what it should be doing, and that is, that project's gonna fit within that strategic plan. And we'll be happy as staff to tell you, this fits exactly what the goal is in the strategic plan to do this or to do that. We'll earmark, and it won't be a paragraph of the strategic plan. It will be a component of where the strategic plan is leading us.
Mr. Chairman? Yes, sir.
What you just said, we all are in agreement on it, and I totally agree with you. I think back to Ralph's point, I think the fact that the board or this committee looks at the RFQ prior to being released probably saves us what Ralph brought up.
Yeah.
If we release it, I believe we're telegraphing to the community that we've all made a decision, that's the next priority, because they pick up on those RFQs pretty quick. So that process should eliminate that.
Right.
This committee and board would have input.
Right.
Again, I commend the staff, they got a lot of work to do.
Yep.
Again, one side of us is saying, let's move this thing, let's get
Absolutely.
going, we need facilities, we need all that, and at the same time, we're saying, we want to look at everything, so somewhere we got to find to move along, so I think you've got a plan, let's try it.
You're right, Charlie. I mean, the pressure to get moving forward is no higher than ever after today's information. But the board's need to hear the information to make sure we're proceeding correctly is not gonna be predicated on who wants to go quick.
And
It's
I
making
commend
sure
you, I
we do
think
it right.
today's been a good working session.
Yeah, it has.
I think we're all in agreement, Chuck's chair. I think it's.
Well, sort of.
Well,
What I don't understand is we put an executive committee together, and it would seem like you're the funnel to make sure that it's pretty much like you believe the board wants to see before it gets to us.
Yes,
So
sir.
I would strongly suggest that this executive committee has got to be right in the middle of this.
You're right.
Yeah,
And
I agree.
that's part of the entire effort today, is to make sure that we've injected that appropriately, and that when it gets to the board, you have board policy input on that process. We will make sure that happens. All right.
Good.
Any other questions? Gentlemen, thank you. Today's a good meeting, because today gives us operating instructions moving forward on what to expect and how to do it. And, you know, sometimes you just have to make sausage. And that's what this process is right now, but it's gonna work fine. We appreciate all your effort, the priorities that you've put forth. We look forward to continuing to work with you on this, not only on the executive committee, but back before this committee, as well as the board itself. So, any other questions or discussion? Yes, sir.
I'm sorry. I should have said it earlier. I think it would also be helpful with that executive committee that's formed, that at some point Broadus and Mr. Lane understand each of their roles as we put together any plan.
Yes, sir. Yes.
So that there's not a dispute on who develops what going forward.
Yes, that's right. And I think that's part of what the executive committee has to do. No question about it.
And let me also remind the board, and probably a reminder to staff, it's been a while since we've done this. It's been a while since this board sat around and talked about capital expenses. It has certainly been a while since this board has talked about what they do with bond money, because the last one was passed 37 years ago. So there's going to be a little bit of rust to the process, and there's going to be a part of this as we go through, in order to be fair to board members, fair to staff, and certainly fair to our community and the ultimate winner, the patient. We're going to go through some of this till we get that process down where we are not only comfortable, we're fair, we're obvious to the taxpayer, and we're obvious to the people, the 80% of the people that supported this in our community, and I think we can do that.
I think it's a positive meeting, Trent.
One foot in front of the other, right? And we're gonna make progress. Okay, with that, then we're gonna adjourn the meeting. It's 3:03. Thank you all very much for being here. We got a lot of work to do.
So, y'all didn't make
15, 16 hours. First thing I have is any citizens wishing to address.
We do not at this
No.
time. No, sir.
Next is, item number 3 is approval of minutes from May 6th, 2021.
Move to approve.
Second.
Discussion? All in favor, please say aye.
Aye.
Those opposed, say no. Motion passes. The next is the approval of Tarrant County Hospital District policies and/or plans. Daphne, are you gonna?
Yes, I think I'm first on the list, and just to try to make the committee's work a little more efficient here, we provided all of these policies that are listed in item 13 in the portal, and this is just part of our triennial work to bring these up to date. I don't believe that there are any substantive changes, but the presenters are in the room if you have any questions. And we'd like to, if there's no questions and everyone's had an opportunity to review, just get these approved as a slate.
Does anybody want to pull any of the policies to review them?
No, just have a question, quick question. Why would the subpoena involving patient employees under Adam Lane?
Hit your deal on. What was the question?
Oh, number 13?
The last,
The environmental care policy in Adam is not it's a security policy, so it falls
it's
under,
under, so under facility?
Yes.
Okay,
Yeah,
just want to make
awesome,
sure.
sorry.
Thank you.
Okay.
So Daphne, for the reason that you said these could all be done in total, is that an attempt to make you exceptionally popular, or is that just because it's fact? Because you just
Both.
made yourself incredibly popular.
It's both.
Yes.
Okay, just making sure.
Okay.
she was popular before. I still want to know who made you sit back there.
Well, it may have been an argument between Mr. Zimmerman, who wanted me completely out of the room, and Dr. Weber, who wanted me at the front, so maybe this was the...
Okay.
Boy.
I understand.
Dr. Weber, Daphne may not have ever been to a full in-person meeting, so she probably is not aware that a lot of times staff will go sit at the table. We didn't prep her for that. I didn't say anything.
Policies for detention. Number 14?
Well, we have a board meeting coming up,
Oh, okay.
for sure. Okay, then, I'd entertain a motion that we approve all these 1 through 13 policies.
Move approval of the slate of policies from 1 to 13.
Second. Amanda, second.
Amanda, you got that shown? Discussion, anybody? All in favor, please say aye.
Aye.
Those opposed, same sign.
Okay.
Motion passes. Number
Gee, that
4
was
is
fast.
consider performance improvement reports updates not requiring action. First is, Rob, you can take that thing off. PSI 90 and quality scorecard. I haven't seen Rob in over a year either.
I know, not in person. Although, you know, I've been doing these meetings, as everyone knows, without any sort of microphonic need, because I can project my voice easily all over the county. Not any difficulty, but I am on the mic this time, so if it's too loud, just let me know.
Right?
So, all right,
Fire away.
so let's get going. So, as I do every month, we'll begin by updating you on our progress with PSI 90, which is our quality pillar goal. We had a return to better in the month of April. So we had 3 challenging months, as I'll show you, in January, February, and March, driven very substantially by pressure ulcers, very significantly in the COVID population. Turns out these COVID patients also have a thrombosis-related dermatopathy, or a problem with the blood supply to their skin that makes them particularly prone to skin breakdown in the hospital. And then on top of that, if you look at all patients who need to go prone in order to be successfully ventilated, which a lot of the COVID patients need, roughly, if you just look at that population, aside from COVID, just in large studies from other settings, roughly 35 to 40% of those patients will have some measure of pressure ulceration just at baseline, because we're not meant to be, cared for laying on our tummies as a usual thing. And so those were big challenges. And those things really drove most of the challenges that we had around this particular measure. It's of also note that CMS has excluded this quarter for measurement for CMS STAR, Hospital Compare, Values-Based Purchasing, and the HAC reduction program, Hospital Acquired Condition Reduction Program. So CMS has recognized that this was a pretty brutal quarter for hospitals really all across the country, and have consequently made the decision to exclude that quarter. Fortunately, we were pretty darn concerned about the fact that because we watch this all the time, we were very concerned about these harm events coming to our patients, even if it's there's some extraordinary circumstance. And so we took very aggressive measures, and the last 2 months, we only have April to present just because of the time of the board book, but May was even better than April in terms of our performance in this measure. And so we've really snapped right back to where we were performing prior to the big surge of cases that we had associated with the winter months. So you can see this is our performance year-to-date, month-to-month in terms of the overall measure. And so we started off the year in good shape. We had those 3 tough months driven by pressure ulcers. We snapped back into shape in April, and May was even better. I should point out that the lowest possible measure, and this is just shows you that things that come from the federal government can be kind of weird sometimes. The lowest possible score on this measure is 0.5. You can't actually get a 0. Even if you have 0 events, you get a 0.5. And so, yeah, I appreciate the look on your face, Dr. Weber, very much. It's one of those just weird things. But anyway, so 0.59, 0.75, those are very good numbers. And the score in May, I think, was 0.58, so another really strong month of performance, which we'll show you officially next month. So you can see what's been driving this. We've had a couple of post-op sepsises. We're still ahead of, if we don't have any more this year, we'll be ahead of last year's performance, so we're hoping we can hold the line on that. I should make a point about the DVT and PE situation. So when we got some of the details out of the leapfrog grade that we talked about last time, when we got to move into the B range, which was really exciting, for the period of time that we were being measured for leapfrog, our DVT PE rate at that time was 3.9. And as you can see, going back now to all of fiscal 2020, we were 1.44 for fiscal 2020, and so far for this year, we're 1.36. If you look at the national data from leapfrog, the best in the country when we had a 3.9 was 1.56. So we may, it's possible that other hospitals have also improved dramatically, but that 1.44, 1.36, as far as that particular measure represents probably, top of the country performance, maybe not the top. It's possible that that won't be the case, but certainly we're right in there with the best performing hospitals as far as this particular measure. So that's pretty exciting data, actually. So we'll keep, and there have been a lot of work that has gone on around DVT and PE prevention. When we had the 3.9, we put a big task force together and created risk stratification tools so that physicians can correctly choose the correct prophylactic measures to prevent this, so whether medications or mechanical means to prevent these harm events. And one other thing that's really cool that we do, and this will interest Dr. Weber, is a trauma program. We're probably best in the nation in terms of starting DVT prophylaxis very early for our patients. So, you know, for example, if you come in here with a traumatic brain hemorrhage, if you have a stable CT scan, we'll start you within 24 hours of hitting the door, and that's been very aggressive, and we've had no adverse events from that, essentially, and have prevented undoubtedly a lot of DVT and PE. So that's really been some phenomenal work that has gone on here at JPS to drive that rate to some of the best results in the country.
Is that number included or excluding the COVID-19?
That actually, so the thing that's really important to notice, so I would say in general it excludes because it's post-operative, perioperative, so most of the COVID patients don't get surgery. It's not a surgery, you know, there's not really a surgery for COVID, so most of those patients did not fall into this surgery bucket, but yes, there's no doubt that a lot of those patients had a lot of thrombotic episodes. A lot of them actually were started on total anticoagulation, not just prophylaxis, but, you know, heparin, you know, real full dose anticoagulation to try to mitigate that situation for those patients, but most of them didn't require surgery, so they wouldn't fall into this bucket.
That's why you didn't get that answer question from her.
What'd you say, DT?
It's picking on me.
Okay.
So we'll talk more about hand hygiene in just a minute. Our colon surgery results so far this year have been very good, probably the best we've seen in a long time, with a rate of 1.02, so that's really phenomenal performance. I think that's the best I've seen. It's not a complete year yet. Last year wasn't bad. Now we're getting down to a ratio at expected for our organization, which is really exciting. I mean, I think most of the folks on the board have been around long enough. Certainly, DT, you and Dorothy have been around long enough to know when that number was sitting more like 2.5, 2.8, 3, and we put a lot of, you know, energy and focus around driving colon SSI better. I think that was fiscal year 2018 that we did that. So to see that effort has continued and continued to improve, I think is really wonderful. We've also put a lot of attention around our results in total hip and knee arthroplasty, and continue to see very good results there. We had a bit of a challenge in 2019, and we've kind of beaten that back very successfully with huge efforts from the joint surgeons and classes getting the patients ready, and a lot of work with surgical optimization. So those results have remained very favorable. The big challenge on this slide, as you can see, is central line associated bloodstream infections. This was substantially driven by COVID. As you can see, going back into February, there were 5 in that month alone, and there were even more in January before that. So that's been the real area of challenge, and that's been very directly related to COVID. And as the COVID volume has dropped in the hospital, so is that situation. In addition, there's also been a lot of work that's been done to try to reduce that, to go back to basics, make sure all processes, all practices are are as they should be. And so we've had a couple of really strong months in CLABSI. CAUTI is also improving. We did very well in May in that, so that's also heading in the right direction. So I'm overall very pleased. We remain one of the best hospitals in the country in terms of MRSA bacteremia, so that's been a strong area of performance for us. And C. diff is performing better than last year, so those are all really good things. And so that's the end of that report. Are there any questions that I can answer for anyone?
I think the public ought to be real proud of what gets done here. If you're a patient, because there are a lot of places that don't even come close to this kind of data. So congratulations to the nurses, the techs, the doctors, you name it, just A-OK.
there's a tremendous amount of outstanding work going on in these things. And I think that probably the most important thing is we never take our eye off the ball on any of this. We just keep our eye on it, and when it's not going the right way, we just jump all over it, even in the case of COVID, where it was, there was clearly an association with something that was an extraordinary occurrence, but, I don't think anybody feels very good when we see numbers that show that our patients aren't doing as well as we would want.
Alrighty.
All right. So every year I'm supposed to come and tell you all, and this is something that is in the Leapfrog survey. Every year they would like to see us tell you how we're doing in hand hygiene, and it's really important, actually. I mean, everything. I'll editorialize for just a moment, but everything that they ask you to do in the Leapfrog survey is stuff that's well worth considering. It's a lot of really strong practices, and so they think that hand hygiene is so important that the board ought to know how we're doing and what we're doing about it. And I think that's a really strong practice, because all this infection prevention work that we're talking about is really underpinned by how well we do with hand hygiene. There literally is nothing more important to do in terms of driving the best possible performance in hand hygiene, in infection prevention, than washing your hands. And so this is really important. So we continue to perform very well in hand hygiene. This is the last 12 months. We're above 90%, which is great. I would love to see it get closer to 100%. Maybe that'll be a good thing to do if we continue to not deal with major COVID surges, where with stressed out staff and all that stuff. This may be the year to push yet higher. But I am glad that throughout the pandemic we maintained the performance that we had previously attained, with all the good effort from past years. If you recall, when we started this focus on hand hygiene, the number was like 45%. So the fact that we've been able to sustain above 90% is pretty good. I think, one of the things when you've got, something like the pandemic is you can't push everything all the time. You've got to respect the fact that people are under stress. So the fact that even stressed out folks did really, really well is fantastic. But I think it may be now time to push a little higher, so we'll see.
Can I ask a question? Because
Of course.
I don't sit here in quality very often, so I'm learning about hand hygiene. It would seem to me that in a hospital that number would kind of automatically be 100, but what is the definition of hand hygiene? Is it simply washing your hands 25 seconds? Is it, sterilizing in and out of the room?
It can be either, but what we follow here at JPS are the 5 moments of hand hygiene. So it's how many of the opportunities of the 5 moments, which are put out by the World Health Organization, what proportion of those 5 moments are honored. So the 5 moments are on the way into the room, before you touch the patient, before you, like if you're handling any body fluids, before you begin a procedure, and after you touch that stuff. So there are 5 moments. You got to follow them all. And if one of our secret shoppers sees you missing one of those, it counts. And so there's a lot of opportunities for hand hygiene, as you can imagine, if you're following the 5 moments. Yeah, so yes, it should absolutely be 100%. I've become increasingly maniacal personally about this in my work because I see the data and I know what's important about it, and we preach it and we teach it and we are doing very, very well, but we need to do perfectly, and that would be the ideal. And so I think, as we have the opportunity to continue to push, I think we're getting to the point where it's time to push to the next level. So going from 45 to 90, that was pretty cool. Now we need to push a little higher. So
let me interrupt you for just a second. During COVID, I was a patient here, and that allowed me to watch everybody that came in and out and whatnot, and every single person washed their hands.
But you're the chairman.
And that was before they recognized me. They did not even get nicer. I'm telling you, being a patient here is awesome. I don't wish it on you, but
I think you answered my question, but I was wondering, how in the world do you measure the effectiveness of this? And you said you've got secret shoppers?
Yeah, we got secret shoppers. Now, there are caveats to the secret shopper business. I will admit that, but I think to Dr. Weber's point, what I see just informally walking around are people washing their hands. And that was, both Dr. Weber and I can remember a time where that was not happening. And
there was a time when we could smoke a cigarette in between, but those are long gone. My wife was also a patient during COVID, and I was not allowed to be in the room. I mean, but everywhere I could look. That was her request. She told me she was going to do that. Every single person washed their hands. And that was just unheard of just 2 or 3 years ago. I mean, kudos to everybody involved.
Yep, it's good. We're getting there. So one of the cool things that I have to give credit to the infection prevention team, because they have created a real-time observation tool, and they launched that in March, as you can see, and this is the number of hand hygiene observations per month, organization-wide, and as you can see, the new real-time tool is very popular and is getting us a whole lot more observations. You can also see that people were really stressed out about COVID in April of 2020 because they weren't thinking about doing looking at hand hygiene, but as you can see, we now have a very robust data set to work from. So this was sort of the project that did this. So our hand hygiene observations were not as consistent as we wanted. So to improve the number of observations across all units, we created this real-time tool. It was an organization-wide effort, and as you can see, we've had a significant improvement in the number of observations, and so this is really great. And so as we push to get yet better, it's certainly good to have a robust data set to work from. And so we're doing a few things to try to get all of our units up to 100% compliance. We asked them each unit to do 200 observations per month. So and that goes for all clinics, that goes for peri-op, that goes for invasive labs, that goes for endoscopy, behavioral health, everywhere. So, okay.
Good.
And I'll just keep going.
Please.
So COVID update. As I think I do every month, I'll apologize for out-of-date data because we have to get this data in so quickly, and the situation's always very dynamic, so it's always feels rather historic. But here's what's going on in the county. So we've been stable and decreasing for quite a while now, which is really great. So there's probably been a lot of folks who've had COVID out there who have some measure of immunity. Obviously there's been quite a bit of vaccination as well. So we've maintained a fairly steady number of cases. I mean, it's not gone, but it's certainly better. And deaths have also decreased. This is where we stand with vaccine. This is the slide that's now a little bit out of date because I was feeling a little bit encouraged by this because we were kind of holding steady in Texas with 140,000 doses daily as a 7-day average. We've now dropped down to about 100,000 though. So in the last couple of weeks, it's really taken a drop off, and that's unfortunate because at the same time we just opened up Pfizer to 12 to 15-year-olds. So that was a whole new population that became eligible during this more recent phase, and yet we're seeing a drop off in vaccination. I did see some data that, interestingly, at least by polling data, vaccine hesitancy seems to be going down. So there seems to be some disconnect between the uptake of vaccine and this apparent decrease in vaccine hesitancy. And so, so hopefully that'll come together here and we'll get more folks vaccinated. But that's really how we get out of this, is getting everyone, as many folks as possible, immune to the virus so it stops spreading. But that was a disappointment to see the number drop off in the last couple of weeks. So the pandemic is still with us. The disease activity remains relatively low. We have seen a few more very sick patients in the hospital lately. Our overall volume in the hospitals remained pretty low, but the proportion of those patients who've needed ICU care has been fairly high, and we really aren't admitting patients who have had vaccines. So if you've been vaccinated, you're probably not going to come in the hospital, and you're not going to pass away. But we have seen an uptick in patients who are having a tough time. It's still a low number, but it's just something to note that that vaccination is a very, very important piece of the puzzle here, because non-vaccinated individuals are susceptible. So the variants continue to be an issue out there, and we don't really track variants as much in the United States as some other countries do, so we don't really completely know what's circulating in our community at any given time, but we do have to be concerned about those. Great news for vaccinated individuals from the CDC is that folks can now, like we're doing here, liberalize their activities a little bit and be in the same room and actually look at each other in the face and see each other smile. So that's what's that? And wear pants. So that's all I have. I think we have one other presentation today.
Okay.
All right, any questions about that?
Anybody questions for Rob? I guess that's it.
Okay.
You want to introduce the innovation?
Yeah. So
That they snuck
so
in
as we
behind you
as we have been doing on a regular basis.
Come on up.
Yeah, I'll move aside and you can sit down here in just a second. So we have many wonderful programs here at JPS, and one of our more unique programs is our geriatric delirium program. We're one of the few hospitals in the country accredited for geriatric delirium. It's a phenomenal program. Again, it's another opportunity to really put focus on a vulnerable patient population, a challenging patient population, and just that focus alone, provides so many opportunities to make things better for our patients. And so I'd like to introduce to you Dr. Matthews and Carmen Goudot, who run our geriatric program and our geriatric delirium program, and I look forward to their presentation. So thank you.
You bet. You may have to pull the microphones up and then make sure it's got a little green, it's green light, is that?
Well, good afternoon. I'm Dr. Rena Matthews, the Program Director of the Geriatric Medicine Fellowship. And with me today is Carmen, as Dr. Stevenson mentioned, who is the RN Geriatrics Coordinator. And so we wanted to present to you the delirium program. Our executive leadership team responsible for the delirium program includes Ms. Wanda Peoples, Chief of Nursing, Dr. Deedan Dent, Crystal Gandhi, Elizabeth Rogers, Carmen, who's here, myself, Dr. Christian Burton, who's our inpatient lead physician, and our co-champions for our Joint Commission delirium certification was Dr. Leska Hadley and Dr. Cheryl Hurd. So our delirium program targets the 65 and older adult population at JPS, mainly seen in the emergency room or emergency department, the step-down progressive care units, and the medical surgical units.
Yeah, that just That's for you and me, you know.
We are responsible for maintaining the Joint Commission national standards, utilizing evidence-based clinical practice guidelines, and developing standardized, consistent approach to our performance measurement and improvement initiatives. In 2019, JPS encountered 21,490 geriatric patients and had similar numbers in 2020. Of that, approximately 4,300 patients or so were new patients in 2019, and there was a slight decrease, but in 2020. So I want to take a moment to sort of show you the highlights of our program, which include our Joint Commission recertification, which was accomplished in December of 2020. Our initial certification was in 2018. We are members of NICH, which is Nurses Improving Care for Health System Elders. We received the NICH and American Board of Internal Medicine award for Choosing Wisely Trailblazers. And we currently have 170 geriatric resource staff members across our health network. We've partnered with UNT Health Science Center for a HRSA, or Health Resources and Services Administration grant, which focused on the workforce for the geriatric population. There are several initiatives within our health network that are funded by this grant. We also participate in the Geriatric Practice Leadership Institute, which is also hosted by the UNT Health Sciences Center, and have sent a team every year for the last 4 years. In fact, the Geriatric Emergency Department accreditation through the American College of Emergency Physicians was one of those quality improvement outcomes, actually, from one of the team's participations. Going forward, we're trying to position our delirium program to reach new heights by participating in the Institute of Healthcare Improvement's National Age-Friendly Health System Initiative. The IHI focuses on a framework that they call 4 M's. Those 4 M's are what matters: mentation, medication, and mobility. And our first step will be, in this journey, will be sending, or actually was sending, a team to participate in this current year's GPLI. Additional highlights of our program include the Hospital Elder Life Program, which is facilitated through volunteer services. Carmen now will take over and show you some of our data.
You are now viewing the Delirium Program scorecard following the last 12 months of the metrics reported to Joint Commission. Our April measures represent the great work of all the individuals who encounter our 65 and older patients. On the next slide, we will discuss each metric individually, focused on the fiscal year. Let's begin with our delirium encounters with restraints graph. The target is 30.7%, and during the month of April, we were at 33.3%. Although we are not currently meeting this target, we see the efforts both of the diligent work of the staff and our action plan, represented by the current lowest reported measure in the year 2021. Moving to the right, our delirium order set usage rate target is 35.1% and above, and we are currently in the month of April at 56.6%. Moving down to the bottom left, delirium patient days graph, the target is 19 and below, and during the month of April, we were at 9.6%, also the lowest reported measure for this fiscal year. I think this speaks volumes to the delirium program's success. Our delirium patients deserve the best evidence-based practice strategies and optimal quality of care actions that we can take in order to provide them with the needed care for reduced delirium patient days. The mission of the program was to address delirium through early recognition, prevention, and/or treatment in our vulnerable hospitalized patients, and that is what we are doing exceptionally well. Our efforts attempt to impact and achieve positive patient outcomes, reduce delirium patient days, and thus reduce hospital length of stay. The bottom right graph depicts perception of care. The target is 80% and above, and in the month of April, we were at 84.2%. This conveys how our 65 and older population perceives the care that we provide. Yes.
Patient days go down? Can you hear him? Yes. Okay.
Yes, it's all of that. Our delirium workflow, the delirium protocol, the interventions and strategies that we have in place for the nursing staff to take when we recognize and screen for delirium for those patients in an acute state of confusion.
One other thing that may be affecting those numbers, holding over obviously from the last year, is that with COVID cases, as there was, high number of COVID cases, there was probably also likely delirium sort of in those patients as well. And so as those numbers also improve overall, there's less incidence.
I'm not medical, so I'm going to ask some
That's okay.
question here. Is there a difference between this and hallucinations happening?
Hallucinations sometimes can be a symptom or a sign of delirium, yes. It's not crossing over. A patient who is ill, if the illness is severe enough, temporarily, what we mean by delirium is sort of like an acute or a sudden change in their mental or cognitive capacity. So their ability to think, their ability to sort of take in their environment, all of those things are changed. And so when they're acutely ill, when they're like with an illness that causes them to be hospitalized, you will potentially, in some patients, see hallucinations. That's potentially a temporary thing. That's complicated in that both of those things potentially can make it worse.
I'm gonna leave and go in. So, Zillia's here waiting for me.
Who sets your metrics? Who sets the targets?
So there were metrics set when we first were certified by Joint Commission.
Okay.
Since then, we've had a total of 6, and these are the last 4. We were meeting the other 2 within the 2 years. So together, the team here at JPS, along with Joint Commission, the reviewer, will decide and set a target.
Good. Excellent.
Under perception of care, is that the patient and the caregiver, or is that just the patient?
So I started in August. The perception of care was a new metric before COVID. We were doing really well prior to March of 2020. During the midst of COVID, because everything changed and how we were meeting with the patients in the room due to social distancing, it kind of fell off. We revamped it in October of last year, right before our certification. So now, and even before the new year, there were limited, visitation. So not much caregivers to see, but since we've relaxed on it a little bit, and one visitor, sometimes they are available in the room and I go around on them. So I've spoken to quite a few, so it's the patient and the caregiver.
And on the encounters with restraints, do they have sitters with them? I'm not sure exactly.
They do. That's one of our alternative measures before restraint use. So sometimes it can overlap. They'll have a sitter or a constant observer is what we're calling it, a tele-sitter as well. And then the restraints, depending on the severity of the delirium.
Yes, I was going to say the same thing. That's all.
Thank you all for your questions.
Okay.
So we are thinking ahead with expectations to achieve our goals. Recognition as an IHI Level 1 age-friendly health system participant is our short-term goal to align the 4Ms framework with the quality of care that we provide. This short-term goal can eventually lead to a Level 2 recognition as an age-friendly health system that's committed to excellence. When our COVID restrictions are a thing of JPS pass, we would like to relaunch our Hospital Elder Life program into a robust training and engaging experience to expand our opportunities not only to our community volunteers, but also to our nursing programs, our physical therapy, our nutrition, and dietary collegiate programs. In conclusion, our restraint use in older adults with delirium has been identified as an opportunity for improvement. The targeted action plan includes coordinator rounding, focused on suggestions to alternatives for restraint use, also to patient monitoring and ongoing education for our nursing staff. On behalf of JPS Geriatrics, Dr. Matthews and I would like to thank you all for your time, and we welcome any more questions and comments.
Strong work.
Thank you.
Strong work.
Yeah. I have a question though. In looking at your future goals and thinking ahead, because I know with delirium it is family focused also on recovery, on going through symptoms, and a lot of the time the caregivers or the family take a lot of. Is this program with Age Friendly Health System and the work that you're doing with UNT Health Science Center, is there any focus on caregiver or caregiver education or monitoring?
So for the immediate delirium program, that is less likely because the focus is mostly on the care we provide here in the hospital setting. However, there are different arms of what we do in geriatrics that are also tied into the outpatient setting, and there are future coordinations that we are looking at with specifically not just delirium, but more delirium and dementia that sort of focuses on caregiving and education. And so that is something that has sort of been highlighted in the past, and we would like to sort of in future endeavors include that.
One of the things that we've always talked about as a hospital is once they leave our doors here, how are they continuing receiving care? How are we providing that information to the caregivers, and what other supports can we give? But thank you.
Okay, any comments, questions?
Well, I want to say thank you. It was a good program, and it was a good presentation. I wasn't aware that you were doing it, so it's great, and congratulations.
Thank you.
All righty.
Thank you.
Good work. Thank you very much.
Okay.
All righty, well, that's all that I have for the open session. So as soon as they can count us down, we'll
Okay.
reconvene in the executive session. And I think I have to say that.
Do we have it?
We're going to reconvene in executive session pursuant to Chapter 551 Texas Government Code
Okay.
for the following. like to reconvene in open session for deliberation and/or action deemed necessary regarding any matter listed on the closed session agenda. And I don't think there's any action that needs to be taken, so I'd entertain a motion that we adjourn.
You got it.
All in favor, bye-bye.
All right.
Great meeting.
Thank you.
Thank you all.
Wonderful meeting.